Ever open a medical bill after a procedure and feel like you're reading a foreign language? You thought you were covered, but instead you're staring at a maze of codes, hidden fees, and out-of-pocket costs that your insurance somehow missed. That exact frustration is what the 2026 Health Legislation Amendment Bill is trying to fix. It forces private providers to clearly publish their medical fees and gives the government tighter control over how much private insurers can increase your premiums. It is a practical, necessary step, but patching a leak doesn't fix a broken foundation. Right now, the Australian government is spending nearly $7.9 billion every single year just to subsidize private health insurance rebates. The very fact that we need federal legislation just to see what a doctor is going to charge us reveals a structural defect. Our health system has become heavily dependent on an opaque private market that requires massive public support just to keep running. To understand exactly how we got here today, we have to look back at the original design of Australian healthcare. There is an implied social contract built into this system, a national promise that your health is a shared public priority. The deal is straightforward. If you get sick, society will take care of you. Your access to a doctor or a hospital bed shouldn't depend on how much you make or what postal code you happen to live in. Yet today, the public system is under such strain that 45.6% of the population has been pushed into buying private hospital cover, navigating a fragmented system of exclusions and waiting periods just to feel secure. Our national health has drifted away from direct, universal care. The original blueprint has now been completely overshadowed by private middlemen who increasingly dictate when, where, and how you receive treatment. When we talk about how a government should design a health system, we can use a simple filter called good public purpose. The goal is to make people well, rather than generating a profit from their illness. Under good public purpose, the government's first job is to build a floor. This means guaranteeing universal, timely access to care that everyone can firmly stand on. Its second job is to build a ceiling. This is strict regulation to protect citizens from being financially drained by excess fees, complex out-of-pocket gaps, and predatory pricing. The biggest threat to the structure is something economists call rent-seeking. Rent-seeking happens when middlemen extract wealth without creating new value. Private health insurers act as these rent-seekers. They don't diagnose you. Instead, they set up administrative barriers inside our healthcare system, prioritizing financial extraction. And this private model is incredibly fragile. In May 2025, Healthscope, Australia's second-largest private hospital operator, entered receivership. When commercial operators fail or pull out, it's the public system that immediately has to absorb the patients and the risk. Pouring billions into private insurance subsidies doesn't buy us better health. It mostly just funds the toll booths that block the hallways of our own public infrastructure. Now, you might be wondering, how can the Australian government actually afford to build and run a massive, comprehensive public system without relying on private money? We often fall into the trap of thinking the federal budget works like a household budget, where you must collect dollars before you spend them. But as former Reserve Bank Governor Philip Lowe and others have pointed out, the national government is a currency issuer. It creates money. Money isn't a scarce resource for the federal government in the way it is for you or me. The real constraints are physical. It's the availability of trained doctors, nursing staff, hospital beds, and medical technology. If expanding the health system is physically doable with the resources and labor we have in the real world, the government can afford it. The true limit isn't finding the dollars, it's making the political choice to deploy them. To see why private markets fail, we must step outside major cities and look at the vast distances of rural and regional Australia. The numbers paint a stark picture. In major metropolitan centers, there are roughly 160 specialist medical professionals for every 100,000 people. In remote and very remote areas, that number drops to just 53. This disparity represents a structural failure of the market model. Where populations are thin and delivery is difficult, providing comprehensive care simply isn't commercially profitable, so private operators naturally don't set up shop. Covering these massive geographic gaps requires direct public investment, coordination, and a mission to serve, not market incentives waiting for a profit margin. A theoretical right to healthcare means absolutely nothing if there isn't a physical clinic or a doctor within practical reach. We cannot rely on private markets to deliver equity. If you want to see the logical endpoint of a health system organized entirely around private finance and insurance, look at the United States. The financial cost is staggering. The U.S. spends $5.3 trillion a year on healthcare, eating up 18% of its entire GDP. GDP, or gross domestic product, measures the total size of a country's economy. Despite spending more than anyone else, the system leaves over 27 million Americans completely uninsured. Life expectancy in the U.S. sits at 78.4 years, well below the OECD average, and their rates of preventable mortality are incredibly high. The OECD is an international group of peer countries used to compare economic and social data. Treating illness as a lucrative revenue stream creates a system that maximizes administrative complexity and corporate profit while completely abandoning millions of its own citizens. The 2026 Health Legislation Amendment Bill is a decent temporary fix for fee transparency, but making a broken system slightly clearer is just a detour, not the destination. We need a staged, deliberate disengagement from our dependence on private health insurance and the billions of dollars in public subsidies propping it up. We can redirect that wealth directly into building real public capacity, more hospital beds, better medical training, stronger regional clinics, and robust domestic research. Access to care must be treated as a universal public right. It shouldn't be a conditional privilege that is rationed by your market position, your premium tier, or hidden gaps. It is time to stop subsidizing the toll booths in the hallway. We have the resources to rebuild our public health system, broad at the base, firm at the ceiling,